Okay, so, okay, can you see it?
Yes, yes, we can see it. Thank you very much. Yes.
Let me go to full screen now. Okay,
Thank
good. So, first of all, I would like, to thank the organizer for this webinar. And the focus here is on the pandemic. As we discussed, what are the drawbacks, what are the advances maybe we can see from this pandemic in terms of patient-centric drug product development, specifically also for older patients. And you might have seen maybe yesterday that the European Medicines Agency finally published a reflection paper on pharmaceutical development for medicines used in the older population that was put online yesterday and finally endorsed on October 15th. Yet I took a little bit more a holistic view here and wanted to a little bit understand what is the change in the development, not only on the vaccines, but in general, how we interact with patients during the pandemic, and what are the drawbacks, but also what might be advancements that we would see. So first of all, we know that the older population is the most vulnerable patient population. And I show you this slide here also to get a little bit more clarity on diseases. When we compare it to the younger generation, we see different patterns of diseases. And the older we are, the more we see multimorbidity. And we are looking here to the older population, male, female. There's really not much difference. We see diabetes, respiratory, and cardiovascular diseases increasing. And these are exactly the risk factors for patients who are suffering from COVID to have a severe outcome. What we also saw from the beginning of this pandemic, that this population, the multimorbid, the older, were considered as a high-risk population. And there was a lot of focus suddenly on this population, which is normally not the case when we look backwards to, disease. We're talking about diseases, but not about population. So COVID really helped us to focus on a specific population, which is the most vulnerable one. And we know that the most fatal impact of COVID concerns this population, and suddenly you see a lot of tools being developed, a lot of awareness which is created around this virus and the population. And this is just here from NIH or the CMS, Center of Medicare and Medicaid Services, where they immediately put on a lot of information for healthcare professionals, for patients themselves, about the disease, about the vulnerable patient population, and what we can do, or in which way we see this population suffering from the disease. And I would say every day you will see new publications coming out on disparities also from different populations suffering in a different way from this pandemic, from this SARS-CoV-2 virus. So it really brought a lot of attention, and even the WHO, which is very much active in this area, as you know, recognized that specific environments are critical, like the care homes, and that we have to protect people who's in their environment. So it's not just about how do we treat people, with what drugs we treat, but how do we really protect people and keep them healthy. And if you see it here, we see suddenly a focus on COVID-19 for older people. So very specific population that suddenly gets into the focus of our healthcare services and healthcare deliveries. Indeed, the impact of the pandemic on the pharmaceutical development and how we run clinical trials, how we treat patients, so in a day-to-day care, had a significant impact on the clinical trials. And there was a very interesting publication which also appeared very recently, that the new trials, new clinical trials that started and which are recorded in the clinicaltrials.gov website really went down in the peak months of the pandemic, where everybody was shutting down. We did not understand the virus. We don't know what to do. But you suddenly see that over the months we start to recover. And this recovery basically shows us that we are starting to understand how we can deal with the situation. And you also see that due to the COVID, a lot of clinical trials were suspended for a while. And this stays at a still quite a high level, but you know, somehow we have to deal with the situation, and you can see that the new suspension went down significantly. And a lot of trials were restarted over the last couple of months. Now, why does it happen? When you ask clinical trial investigators, and here there were a total of 245 which were surveyed, on the percentage of patient and sponsor contract research organization interacting, which were taking place remotely, you suddenly see that before the crisis there was only a very, very small percentage of remote clinical trials, and at crisis this raised extremely high. So we went from the face-to-face more to the remote. And the expectation is we learn. We know what works, we know what don't work. But when we suddenly apply these remote clinical trial settings, we see that surprisingly things work, which we consider as, you know, it will be difficult, I don't know, we cannot, we can't. And suddenly you see that, well, we say we might continue to use a number of these remote clinical trial settings even beyond the pandemic. And that is what you can see here, the percent how we interact with patients, like healthcare professionals interact with patients, will be maybe tripled roughly after COVID. So a lot of this will be maintained even if the pandemic is over. So we move from a typical face-to-face, and we learn to use how we can apply remote healthcare, either delivery to patients or in clinical trials, where we can apply remote assessment successfully. And what investigators, when they were asked whether, you know, the clinical trial intervention presented in randomized order would increase in adoption post-crisis, and to select up to 3 interventions which they believe would sustain, you see that telemedical consultation, remote patient monitoring, e-consent, e-sources, and so on are expected really to be maintained post-COVID. Simply because we suddenly apply these technologies in the absence of personal contacts, and we identify how nicely they will work. So the pandemic gave a real push into using new technologies like digital health, like telemedicine and remote control and monitoring of patients, and brought us a huge step forward simply because we have to use, there was no alternative. We also saw that over the last years, a lot of things have changed. We started from the typical development passes where you go through the phase 1, phase 2, phase 3, and pre-registration, which were no longer possible in the rare diseases, orphan diseases, and specifically not in the new modalities, the CAR T-cell therapies, where we learned over the years before pandemic that we might have different ways of doing our clinical trials. And there was a huge number of work being done on what was called the adaptive design in clinical trials. And this was really released as a guideline from the FDA November 2019, so just before the pandemic started. And during the pandemic, as you know, we haven't had any time. There was no possibility to plan a clinical trial, you know, to decide on the trial center, on the inclusion, exclusion criteria, randomization, then shipping over the drug, you know, in a blinded way. We used simply this adaptive clinical trial to get out most of what we can do in a short time frame. And these adaptive clinical trials allow much more flexibility and in the design when we see. So we are not just running a trial from A to the end, but immediately see what we learn. And the more data we get, the better we are in understanding possible outcomes, maybe seeing some advantages in certain therapies, add-on therapies. And the major advantages are that it might provide the same statistical power with much more smaller expected sample size or shorter expected duration than we have it in a normal clinical trial. We have the ability to stop a trial early when we see there is no outcome, but also add on new therapies which suddenly evolve as having a positive impact on the typical diseases. And it's about effectiveness in the targeted subgroup of population, which we can also generate during the clinical trial. And patients might be much more willing to enroll in trials that use response adaptive randomization, because this increases the probability that the subject will benefit even from these more effective therapies. And this is one of the trials, this discovery trial, which is a typical adaptive clinical trial design, where you had different arms, a number of patients, and during this trial, you adapt while you learn, you skip certain treatments like the hydroxychloroquine. Hydroxychloroquine was skipped and another one was added simply because we saw that this drug was ineffective and another combination might give much better response. So this clinical trial design was luckily developed in a theoretical way and put in some guidelines just before the pandemic. And then during the pandemic, it was just applied. And we now learn that in real clinical trial settings, this adaptive clinical trial might help us to get much faster and much more precise also for subpopulation the results we are looking for, so the verification if a drug is safe and effective. Yet there is this question on excluding, these older patients from the clinical trial. Now, this is a publication which was also looking into how much of the older population we have considered. What you see in this publication, it's saying that it did not exclude patients with common chronic diseases, so the older and the multimorbid. the only thing is that there are risk factors, and we need to make sure that safety first. So you don't start with the most vulnerable patient population in the clinical trials. That's why you still say until today in the vaccines, maybe the older are not represented well. But when you go and look into the clinical trials, you will see that there is no exclusion of older patients. It is just that they haven't yet been enrolled, because this phase 3 trials in the vaccines, COVID vaccines or treatments, are just running for 2-3 months. So we are just starting basically the phase 3 trials. But again, they concluded that they are not excluded, but yet maybe not be included, as these known risk factors may lead to severe illnesses, you know, which have not yet been really included in the existing studies. However, if you look to the clinical trials.gov website, where every clinical trial is listed, first of all, you'll see that the total number of clinical trials on COVID treatment and vaccines is actually 3,611, and that is coming from October 17. So that's the latest. Every day there are additional trials. If you look to the inclusion criteria, the trials to include patients beyond 65, you will see that there are roughly 92% which do not have an age limit, an upper age limit. Yeah, so we need to ensure, and that is also what the guidelines are saying, which the FDA brought forward in March, immediately after the outbreak, is that every clinical trial has to first ensure the safety of the patient and then look into effectiveness. So you would never go directly to the very critical patients. You will move over slowly to the critical patients when you see that the drug is safe and when you believe that also it is safe enough for including the most vulnerable patient population. So why does pandemic might accelerate the progress? First of all, the pandemic was a complete disruption. There were a lot of economic setbacks, specifically for older, because a lot of them had some work, you know, they were doing, and it was harder for them to remain on the work and to stay as a workforce. And a lot had to, you know, pay their retirement, or they are losing savings because they were not able to work. We know that this normally, any disruption affects the older patients much more than younger because of mobility issues and other issues, and that they might have a much more effect on the emotions, on the well-being of this patient. And we know that once the coronavirus infects this patient population, they are at an increased vulnerability. And what I mean is not just during the active stage of the disease, but also during the recovery. A lot of these patients who were on mechanical ventilation have never really recovered completely, and they are still suffering, even though they are free of corona, and the corona was months back that they affected them. And also you see a lot of ageism. Now we see the opposite in Europe. Now it's the younger population who's guilty for the outbreak. You know, in the beginning it was the older guys. So, you know, you see a lot of ageism and stereotype types in any type of disease, and specifically in pandemic. And you see that the lower socioeconomic status is increasingly a risk for severe COVID outcomes. So we had a lot of disruption, which were setbacks, but at the same time, there was progresses. because it increased our connectivity. Older adults, have improved their technology skills, and they gain experience very quickly with online platforms when they see the value. When they are suddenly alone at home and they cannot go to the doctor, and suddenly they know and find a way to connect with the doctor via digital tools. You see that within the families, the young guys, the young kids, they help the olders to deal with the technology and stay connected. We suddenly see a lot of efforts also on the social isolation first, which is a matter of disruption, but how we really reintegrate and provide social well-being to this patient and improve the quality of life. And suddenly we get much more, focus on these patients, which also help the entire society to be sensibilized for the threats they are facing, and then they get support from outside, but also they might develop more self-care and time management capabilities. And there's also, an increasing awareness about the importance of advancing directives and legal documents for these patients, where we are suddenly, seeing that if we want to involve them in this, keeps them integrated in the society, that we need to have new tools for them to protect them as well as to get in contact with them. And there might be also an upswing of the interest among professionals across disciplines to work with older on public health issues, because we suddenly see them getting into the middle of a pandemic crisis where we need to act on. You also see that a lot of guidance or guiding documents have been developed from authorities, healthcare authorities and medical authorities, on how do we really move forward in engaging older patients into clinical research. And this is being done by reducing the burden, by reducing the barriers. And the same applies for the social participation of these patients. And here you see that a lot of new guidelines have been put forward. And yet we are not, at the end, it's still a very important continuing discussion and movement towards really reducing the barriers. And what will be a reduction of a barrier for an older patient is also a reduction of a barrier for younger people, because it becomes more easy to join clinical trials in a very safe way compared to the previous things where you are, or previous procedures which were much more challenging. So we have suddenly an opportunity to really make an impact on our older adult patients. As the pandemic really drives us or pushes us to improving the way how we do clinical research and how we get access to the patients. And there are also new initiatives which are running. Yeah. Like here, you can see the digital health trials to improve the clinical trials, which is also a governmental initiative where everybody can get in, get on, and define novel endpoints, digital health technologies. We start to decentralize the clinical trials. So simply imagine that an older patient needs to go back to a clinical trial center to be monitored. And if you do it 3-4 times for older patients who have mobility issues, that's a threat. they will not be able to do. But if they are sitting at home and can do it from home, that's much more easier. And you can more engage with patients and site, and you have also new tools in feasibility studies database. So there are a lot of opportunities still what we can do with this pandemic impact, and where we can leverage digital technologies much more to transform the clinical trials. And in this publication, you can see that they made a number of good suggestions on what we can really gain from this pandemic to run clinical trials. Also incorporating technologies, new technologies, and committing to use the digital technologies also to address the disparities. Not everybody has these tools, and we can make an investment in the next generation of workforce in medicine and clinical technology and research that we can really learn from it. So in conclusion, the pandemic was and is a complete disruption of the established processes in drug product development and healthcare provision, causing reactive shutdowns and discontinuations in the beginning. Yeah. While such a reaction was mandatory in the beginning, it is not sustainable. We cannot say we shut down and then we wait until it's over. So we had to react, and the only possibility was to adapt alternative methods and make them directly applicable. So instead of waiting for evidence, clinical evidence and trials and processes, there was no other way of doing it. We had to use. And the requirement for such alternative and new technologies is that we need to select them based on readiness. Readiness in terms of technology, but also in terms of people. And I think that over the last 10 to 15 years, we have advanced tremendously in technology, and also people get much more used to such technologies. We need to also look into the risk mitigation. We should not take any, unsafe new tools or tools which, have a high failure rate. During this pandemic, we had a lot of learning and optimization of tools, because we applied them as they were, and then we see, well, certain things work, others don't work, but the things which don't work, we can optimize, we can go over. And while we were doing it, we validate the technologies, but also start to valorization. That means we see the values, we see basically the advancement and the savings and the ease of access of patients based on these technologies. So we get and move much faster with innovation than we would have done without this pandemic. And a good thing is, even though we will return to normality after the pandemic, the lessons we have learned taught us things in much less time than before, because we did it and we suddenly see it works. So the new normality will not be the normality of the past. It will be a normality which is much more in the future. We will then no longer give up this lead, which means, you don't go back to something which you consider suddenly as being, middle age. Yes, certain procedures will go back to certain procedures, but in others, you say, why should we do it? If we have a remote monitoring of patients, why should we call them to our offices every month for control in clinical trials? So that's why I'm very confident that the pandemic gave us a huge push in terms of advancements, but also in a lot of hopefully in a lot of other questions, specifically on the ethical side, on how do we deal with this kind of vulnerable patient population? How do we really consider our limitations in healthcare and our delivery of healthcare to patients? And there was one very interesting thing, which was just, I think this morning, I heard it, that a number of pharmaceutical companies have asked the FDA on clarity on how do we want to proceed with our clinical trials on the vaccines. Yeah, because normally we are following up the patients then over 2 years, yeah, or at least 1 year. But how we are dealing with the patients who are classified in the placebo group? Do we want to leave them in a placebo group when we have an effective vaccine? How do we deal with this situation? Because we don't want to let patients under the belief that they got a drug because they joined a phase 3, but they just got placebo. Yeah, and at a certain moment, we have to break this blindness of the study. And that's a very important and ethical question, because we cannot say, now we have an effective vaccine, but the people who were classified on the placebo arm of a clinical study, that they will not be informed that they got placebo. And having said this, I'm at the end of my presentation, and if there are any questions, I'm happy to answer them.
Thank you very much, Professor. Thank you very much. It was a great presentation. We are so honored to have you here. So is there any question let me see, there is one question, if I can see. Yeah, Margaret, can you ask this later or write directly to Dr. Morgan? Yes, there will be. We have discussed this earlier. There will be a vaccine in 2021, but probably in the second half of the year. Dr. Morgan have given an explanation about it, but if we have time at the end of the program, he will come back to you and he will give you another answer. But otherwise, there will be a recorded version of this whole webinar, so you can go through and listen to his answer. Okay, thank you very much. Yes.
Can I just, it's actually more a comment and a question to Sven. Sven, thanks a lot. It's for a very documented and insightful presentation. The first observation is that I cannot agree more with you that we are seeing lasting changes in the way clinical research is going to be conducted. And in a way, this epidemic has been fostering innovation and stimulating the creativity of companies, and some of those changes will be there to last, and certainly for the better, and maybe a greater comfort or a greater acceptability of the execution of the clinical studies from the patient perspective. The second thing that you mentioned about the how do we handle subjects who received placebo in the phase 3 studies. What I can share with you is that, and this is agreed upon between the authorities and most manufacturers that I'm aware of when I'm aware of this subject, is that when you unblind the study and if the vaccine is demonstrated as clinically protective, then there's a disposition whereby the subjects who receive the placebo can receive the vaccine for free. In other words, there will be other doses that are set aside to immunize after the fact the subjects who receive the placebo, again, if the vaccine is demonstrated as clinically protective.
Okay, yeah. I was just a discussion I followed up this morning, and I was surprised because a lot of this question we never had to ask before, and suddenly we are dealing with quite important questions which just arise.
No, absolutely. Your point was excellent, and it's both. I would say it's essentially an ethical point to begin with. I mean, why would you leave someone who has received the placebo and actually contributed to demonstrating the value of your product, possibly taking a risk? That's the principle of randomization, and not sort of assume the moral responsibility of providing that person the right response as soon as it is demonstrated as being the right response. So this is now a disposition which is standard in the as I'm aware of in when you discuss the protocol of the phase 3 with the ethical committees in the various countries around the world.
Yeah, thank you. Good comment.
Thank you very much.